So let's think about this particular patient. We're seeing DLBCL Richter's transformation, and we can kind of think about some different therapeutic approaches. There are some kind of more standard approaches, and then there's some novel approaches in development, which I think are exciting. So I'm going to start with Dr. Wierda to review some of the standard therapies, and then Dr. Jain's going to tell us about the novel approaches.
So standard therapies have been very underwhelming for Richter's transformation. We've done a lot of work looking at various chemoimmunotherapy regimens, and the outcomes are very poor. Overall, the response rate's about 50%. It's very uncommon to get a complete remission. Many times, Richter's transformation is associated with 17p deletion, mutated TP53. Chemoimmunotherapy just does not work well for these patients. It can gain temporary control of the disease. You can debulk the disease with a chemoimmunotherapy regimen, but it's transient. And so if I am ever considering chemoimmunotherapy for these patients, it's with a next plan, like transplant. So if I have a donor lined up and we're ready to go to transplant, I may consider an intensive chemoimmunotherapy regimen to get that patient in a good debulked state so that they can proceed with transplant. But we've done very poorly at treating Richter's transformation. We just have not yet identified good therapies that get good durable disease control and remissions with Richter's. Transplant probably has performed the best thus far for all the treatment options that we have for Richter's.
And just to be clear, allotransplant is what you do?
Allogeneic stem cell transplant,
okay.
Yes.
Great. So Dr. Jain, that sounds fairly grim. What are the new prospects for therapies in Richter's?
Yeah, so there have been several clinical trials which are ongoing right now, looking at some novel strategies. So one of the strategies, which I think most data right now is with the checkpoint inhibition. And this work initially actually came out from some pilot work done at Mayo Clinic, and they have subsequently reported their findings, where they showed that in 9 patients with Richter's, 4 of them had a response, and most of them were ibrutinib-treated patients. And interestingly, in that particular series, they treated 16 patients with CLL, and this was with pembrolizumab, single agent. They did not see any response, but again, 44% among the patients who had Richter's transformation. And the median overall survival for the Richter's cohort was 10.7 months. So, and we have also at MD Anderson, we have been doing an ongoing trial. It's an ongoing study right now, looking at the combination of nivolumab, which is another checkpoint inhibitor, a PD-1 inhibitor, in combination with ibrutinib, both for relapsed refractory CLL and Richter's transformation. And when we reported the data last, we had treated several patients with Richter's transformation, with again some of these patients achieving partial remission or complete remission. So I think there is activity with the checkpoint inhibition for patients with Richter's. Recently, there was a study reported at the ASH meeting, this past ASH meeting, a large study looking at the nivolumab and ibrutinib, so PD-1 plus ibrutinib for patients with CLL, and that also included patients with Richter's transformation as well as other non-Hodgkin's lymphoma histology. A large study was done, total of 141 patients were treated. And among the Richter's transformation cohort, they saw 60% overall response rate. So again, it shows, all these 3 trials show that there is for sure activity of checkpoint inhibition in patients with Richter's. I think the work which is ongoing right now is which patient will respond to checkpoint inhibition. I think that's something we don't know right now, but we and others are trying to investigate that. So that's one strategy, looking at checkpoint inhibitors. There are other efforts. You are leading an effort with the venetoclax plus chemotherapy approach, which is again an ongoing trial. There is preliminary data, clinical data that Richter's transformation, patient with DLBCL and Richter's transformation may respond to venetoclax. So I think venetoclax plus chemotherapy may be a valid approach. I think the more exciting data, which was recently published, was with the CAR-T therapy, so chimeric antigen receptor therapy. The group from Fred Hutch reported data for patients with CLL and Richter's transformation, high rate of complete response rate, PET negative response rate, as well as bone marrow negative response rate. So I think those are the strategies which are in clinical trials. We are also doing a clinical trial with blinatumomab for patients with Richter's transformation, so that's another potential strategy. So those are the things which are kind of in the pipeline, and I think if there are patients out there with Richter's transformation, you should send them to centers where they have clinical trials, because as Dr. Wierda mentioned, with chemoimmunotherapy, their outcomes are quite dismal.
Yeah, and it certainly sounds like there's a lot of work going on in this space, which I think in and of itself is encouraging, but certainly a lot more work to do.